So here's a lady who had a legitimate vertebroplasty, had a good result. And this was the time, the beginning of this millennium, when we felt that vertebroplasty is a panacea for everyone who has an acute osteoporotic vertebral fracture. However, when you start digging into your own results and when you start extending your own follow-ups to more than 3 or 4 months, you start realizing that really funny things start to happen to your vertebroplasty. Because by default, vertebroplasty involves putting a stone in a pile of cushion, and that's not going to work, right? You have a system where the system is failing, and you're putting one cement block in that system, it is bound to crumble. And philosophically, it is, and against the, against the philosophy of orthopedics, okay? But then do we have an option? Let's look at the option, which is a new option. I'm standing here to say that osteoporosis is a systemic disease, and it's not the fracture that matters, it's the person with the fracture that matters. And unfortunately, most orthopods, unlike spine surgeons, seem to miss this. They fix the greater trochanter or the IT fracture and miss treating the osteoporosis, almost like treating the tubercular spine and not giving AKT. It's as bad as that. What are the good things about cementplasty? Yes, it does fill in the bone defect. It gives you immediate local stability. However, it creates a huge stress riser, and the Young's modulus of elasticity really goes for a spin here. And then there are too many contraindications. Let's look at some of the contraindications that we put forth in our paper in the beginning of this century, in 2012 in the Journal of Neurosurgery Spine. So here's a case, again, which looks vertebroplastiable, an alligator jaw defect, which is filled with cement and promptly breaks down, as you take your follow-up beyond 3 months. This kind of eggshell crackling has happened because of the following factors. And these are the factors that, according to me, contraindicate vertebroplasty. Let's look at a few of them one at a time. Locally, if there's, of course, neural canal encroachment. Now, I say this because based on an X-ray, you're not able to decide whether there's neural canal encroachment, and you need to do an MRI scan for every patient that you plan a vertebroplasty for, because you could find that if you push cement in this patient here, you're only going to push that posterior superior fragment back and create a problem which didn't exist to begin with. So get an MRI for all your patients where you plan a vertebroplasty, and a whole lot of them will leak out then. What about non-contained fractures? So get a CT scan for all the patients that you plan a V-plasty for. Like this, which looked amenable to vertebroplasty, it's pretty close to the end plate. As soon as you do the CT scan, you find that they're leaking points, and these will then end up having the cement leak out into your end plate, which you didn't prepare for when you planned the vertebroplasty because you didn't have a CT scan. And this causes a disc vertebral instability, which is a set-off for surgery, because a disc vertebral instability will never heal, no matter what you treat with, and this is a soft tissue instability which will need surgery. A lot of your patients who come up for vertebroplasty have significant kyphosis. Again, by the laws of biomechanics, if you just fill in cement, the cement is going to be under tremendous load and the entire spine will fall off in this situation of kyphosis. What about instability? A lot of your patients who do come with a fracture that looks like a compression fracture actually have a posterior element defect also, and you'll see more and more of them, again, when you examine them clinically, if they have posterior tenderness or if the MRI shows the posterior ligamentous complex as a white line, you got to do surgery for them because your vertebroplasty is going to fail. Pre-existing adjacent pathology, you see more and more patients with multiple osteoporotic fractures. And of course, very severe osteoporosis with a high demand back, which is again a sign of our times. Older people are living younger, and like this farmer, who again looked like a good indication for vertebroplasty. He had his vertebroplasty, but went back to farming at 69. And with that kind of a load pattern on his back, it was only timeline to give way. And you can see this cement has created a dent in the rest of the bone, and this is a point of no return literally for this patient. Now, here is where teriparatide comes in. And what does teriparatide do? For that, you really need to know what is osteoporosis. So osteoporosis is not only a loss of bone mineral, which is osteomalacia, but it's a loss of the trabeculae in the bone. There's defective trabeculae. Bisphosphonates, which was the startup treatment for osteoporosis, would actually fill in these missing gaps, or fill in these gaps created by the loss of trabeculae, giving a better mineralized bone, which would look more dense or feel more dense on DEXA scans, but actually make the bone brittle, because the bone quality will not improve. And that's where all these new subtrochanteric fractures started to surface, because it's a brittle, hard bone, while teriparatide actually magically creates new trabeculae. And that is a very, very new thing for orthopedic surgeons. And this will then fill up the bone completely. So that farmer would actually go from here to here if he was given teriparatide instead of the vertebroplasty, right? So no matter how much surgeons try to leverage and say that vertebroplasty or the surgical maneuvers win the battle, the truth is that medicine actually wins this battle. And here are some case situations where, to finish up, the first situation is when there's a vertebral fracture with early neurology, like my patient who had done the T-lift for, came back with, osteoporotic vertebral fracture higher up with neurology, and she didn't want a resurgery, and she got bailed out with a, you can never get an X-ray like this without teriparatide. Here's another one, situation 2, where there's a failed vertebroplasty, and literally see what happens to this vertebroplasty, which is eroding the adjacent bone. And with teriparatide, you get almost a magic result. I mean, if you publish this, you will know that, your surgery couldn't have done any better. The third scenario is a disaster surgery done by a surgeon in Bombay, and you can't do these surgeries and they start to fail, but teriparatide can actually rescue it. So my concluding remark is that teriparatide for everyone who's eligible for in osteoporotic situations, and vertebroplasty for a very select few. Thank you.